Good morning, everybody. Welcome to day 2. I hope you enjoyed day 1, including the reception last evening. I've heard many people say they're enjoying the meeting. I did think, I'm not sure they'd tell me if they weren't. So I'll take the vibe to say people are enjoying connecting, reconnecting, and being part of this community. I now get to see what's up here. I sat down there yesterday wondering what people are looking at down here. Now I can see. So Heidi and I are going to split these opening remarks, and my countdown clock has started. I apologize to those who've heard me give these slides 20 times. You know who you are. Hopefully for a few people it is the first time we've gone through it. Global Alliance mission is very much about genomics and health. It's not just about genomics. It never was from the very beginning. It was always how can we bring the promise and the potential of genomic research to directly impact human health. It's been a 13-year journey, but we're getting there. From the very beginning, led by Bartha's work, we were grounded in this, from a regulatory and ethics perspective, in the Universal Declaration of Human Rights, and the 2 fundamental rights, the right to science and the right to recognition for the work. And that has stayed from the beginning. It's been revised, it's been updated, and I think everything that's come from our regulatory and ethics work streams has been based on this fundamental basis. From a timeline point of view, we did start the work in 2013. We didn't have the first plenary until 2014, and to make up for that, we had 2 plenaries in that 1 year. And that's why we get to 13 plenaries, even though we only started in 2014. There's been an evolution, and in many ways, it's the natural evolution of an organization that started with a handful of people, a handful of countries and 50 people back in 2013. I think there were 8 countries. And so that the sense of we're trying progressively to get more and more global, but it is difficult to be truly meaningful. And I'll show some slides as how we've reached out, but we've still got much more to do. And we were hearing it yesterday, and I'll pick up on some of those threads. As we went through that transition from the very early days, I would say we were 95% research, thinking about clinical applications. And as we've grown and genomics has grown, the scale of genomes, there were probably 10,000 in the world when we started, whole genomes. We know there's over 3 million today from just the projects that we're working with. So that scale of large-scale genomics has paralleled what we're doing, but also the movement into clinical. The discipline of what you see today and what Heidi will talk about in terms of product development, and not just how we develop those products, how they're approved, how they're implemented, how we track implementations. All of that really started in 2017 when Ewan pushed us to be much more business-like, much more production-like, and get disciplined. Up until then, it was very academic, but from 2017 on, it's become increasingly structured and disciplined. Plenary participation, you can guess what caused those 2 total yellow bars in the middle. COVID was an interesting time for us, and although we got significant participation through that, it felt light. It felt it was missing this personal human dimension. It let a lot of people from a lot of countries get engaged in a way they hadn't been before, but it was a light touch, and you can't build new relationships through virtual meetings and Zoom. You almost have to do it in person. You've got to have an extended conversation. You've got to find common ground. Almost impossible to do on Zoom. So plenary participation, in the beginning, we were measuring it on how many people. And I think where we've got to now is what's the quality of the meeting? What's the output of the meeting? How do we achieve the objectives we set for ourselves rather than just counting how many people came to a meeting? But the hybrid meeting is possible. It's not easy. It pushes our team to its limits to make sure we've got good participation online and in the room. And I think we'll do surveys as we finish this meeting, particularly the online session, to see how we can make that most meaningful, knowing that for half the world we'll be in the wrong time zone So if we're in Sweden, we're a different set of people across the world who are not able to easily participate. In terms of countries represented, you'll see we got the big boost during COVID of countries represented. Travel makes it more difficult. People's, not just from a cost point of view, but from a carbon footprint point of view. People think differently about travel. But we have progressively increased the number of countries participating in plenary. This was our geographic reach in 2012. It wasn't any different in 2013. And this is it today. Where Angela and I then can process this coverage with what we were hearing yesterday is a lot of this, I would say, it should be light blue or shaded because it's a single touch point. Maybe it's one institute or it's one group or it's because a driver project is active in that. So in saying we've reached this global breadth, we're in no way accepting or acknowledging that we haven't got tons of work to do in really important parts of the country. We heard from Bina yesterday about Indian participation. We will check in with you. I think that's the important thing, is we're not going to say this is what we're going to do and it's the way to do it. We'll talk about regional hubs. We'll talk about ambassadors. We'll talk about how best to engage India, which will be different from maybe from other countries. But the concept of recognizing time zones are an incredible barrier. So we need to have GA4GH hubs, networks that can operate in different time zones. What the natural gathering of groups is, we need to engage with people and say, you're our most active group in this part of the world. How can we fully engage everybody around you? And that conversation is going on right now. Angela goes to China next week. I go to Indonesia in a month to the Asia Pacific Congress, Human Genetics Congress, to listen, to learn, and to understand what we need to do better, what we need to do differently. This is a community. I think you've seen many of those names. It starts clearly with our funders, then it moves to our host institutes. There is this small keystone in the middle called GA4GH Inc., which is the legal entity that binds it all together. But in fact, 95, 96% of the work is done in the host institutes and out into the community. And then this large community, we think the biggest number we've got in all our contacts is 11,000 people in our contact list. We've got regular communication with about 4,000, and we have about 400 active volunteers. So that sense of big community enabled by these host institutes is the way to think of it. The host institutes are not GA4GH, they create GA4GH. Funders, driver projects, it really started with 3 host institutes doing it by themselves for the breadth of the community, and it moved to what you see today. And if any of you want to participate in any of those ways, host institutes, regional hubs, funders, then we are open to a conversation. And we're in fact going to have a couple of those conversations at this meeting. And I'm going to pass over to Heidi, who's going to get more into how we work and the products we've delivered.
Thanks, Peter. So just in terms of how we work, we have 5 strategic partners at this point, groups like Elixir and others. We have 28 driver projects. These are stable, well-funded genomics programs that commit FTEs towards our work, and we do have periodic calls for those driver projects. And as Peter mentioned, we have organizational members. I think there's a missing number after that 5, Angela, right? We have more than 5 assigned experts. Oh, well, these are, okay. These are, dedicated, funded off a grant, like fully allocated. And that's different than many of you that are part of driver projects that spend a lot of your time on our projects. And we actually want that number to get higher. And then we have 450 or more individual contributors. But what all of these individuals are doing is really part of our ecosystem of defining the needs for our community in terms of standards development, and that starts with study groups that actually look at the landscape. We don't want to develop standards if they already exist. We want to use what's already out there or build upon it. And so those study groups really define needs, And then our work streams are the ones that create standards and the policy frameworks. And they do that with the input of both our driver projects as well as the National Initiatives Forum and our communities of interest. And I have a slide on the COIs in a second. And then we go through an implementation stage with driver projects and many other groups out there, organized through our GIF forum, the GA4GH implementation forum. But that continues to cycle because standards need to evolve as needs evolve. So these are the 8 work streams: ClinPheno, Cloud, Dury, Discovery, GKS, Large-Scale Genomics, RUSE, and Data Security. And they really are the workhorses of the standards development process and the policies development. You know, a few years after we formed GA4GH, we recognized that there was a need to bring together the communities that had overlapping and common interests. And so over the years, we've launched multiples, cancer, infectious disease, rare disease, neuroscience, and most recently, the Clinical Genomics Laboratory Forum. And so this is a way we can bring common interests and help feed that in a more consensus-driven process into our work streams and the products that we need. We also, and this came up yesterday a few times, we work with other standards organizations. Again, we don't want to duplicate work. We want to be interoperable across different standards, so particularly in the clinical space, but OHDSI, I think Odyssey is that orange and black box that built the OMOP model that's used commonly in our clinical consumption. But there's other standards in this space that we work closely with, and that's really key. This is my last slide, and then I think we'll take it, open it up for some questions for both. I'll call Peter back up. But this is really looking at the sort of genomics and health ecosystem of how we use our standards to enable all of our work, whether it's engaging in recruiting patients to cohorts, how we define data access, data stewards, regulatory and ethics committees that define who can use our data and how it's used, standards for genomic sequencing and consent forms and data donation. All of these different things are the standards that are enabling the work that we all do in our genomics and health research and clinical arenas. And so to date, up in that left corner, I think we've launched about 44 different products. And then also now a really huge focus is making sure those products are fit for purpose and actually enabling the work we want to do. And that is where we focus now a lot more on enabling implementations. It's not GA4GH's role to actually do the implementation. We don't build the platforms, store the data. We enable that. But it's important that we're part of that step to know that our standards are fit for purpose and can enable it. And if they aren't, we bring them back in-house and we fix them and put them back out. So this is sort of that ecosystem. So with that, actually go back. We have 7 minutes left. So Peter and I are gonna just open the floor for any questions, future directions for GA4GH, anything you wanna shout out, say, ask us. The floor is open for 6 more minutes. And I'm sure some. Are we using Slido?
Are we using Slido?
No, we're not using Slido.
So if anybody was pounding on the phone, putting a question.
That's right. Yes, Sue. Oh, yeah, we can share one up here.
Thank you very much, Sue Hill, Chief Scientific Officer, NHS England. It's great to see how far GA4GH has come, and thank you for setting it out like that. There's a real opportunity, I think, as we're forming the Global Genomic Network for Education and Training to work more closely. My question, 2 questions. One, do you see more virtual developments as you move forward, especially through those regional hubs? And then for you, Heidi, I'm really interested in the governing outputs part of the slide. you've just put up, because we've been dealing with issues about reports that, especially when they're done by third-party providers, so not within the NHS, where they don't conform to a set of standards. And it would just be helpful to know what you're thinking about.
Yeah. Do you want to answer?
So thanks, Sue. First of all, I was talking up GGNet yesterday to somebody. They were asking, are we doing anything? And I went, no, but somebody is. You need to meet Sue when she arrives tomorrow. I don't think we have a number for how many virtual meetings we have. It's just Zoom. It's got to be well over 100. No, it's more. Can somebody count up how many virtual meetings we have? Just look at the calendar. So literally every day, every work day, there will be a Zoom meeting involving that's for a group of people who are already working together. Some people can join it, but what we're finding is the onboarding, the connection, it's much easier to get people together in person to start the work, but once it's up and running and they've got a mandate and they know what they're doing, virtual is a very efficient way of doing it. So I assume as we get the regional hubs up and running, it will be a combination. We'll go to a part of the world, we'll have like a mini plenary or a regional meeting, we'll get people together, and then we'll talk about how they participate in global virtual meetings and how they can host local virtual meetings. And the biggest single issue is time zone for that.
And before I go to your second question, I'll just add that, like dealing with the time zone issue is a huge and a real, problem. And so, I've been encouraging some of the groups to actually alternate their meetings. Like for Federated Nomad, we have one meeting every other month. We alternate between 8 a.m. East Coast time and 4 p.m. East Coast time, because half the world can join one and half the world can join the other. We do the same thing for variant level matching, as Nara mentioned yesterday. We do the same thing for the clinical genomics laboratory community. We alternate 2 and every other month, and then we record them all so that what the one that happened while you were sleeping, you can at least watch, afterwards. And I think that is really critical. We can't just pick the one best time that suits 70% of the group. You really need to think about how you're going to engage both. So if you're in a work stream or a study group or the many groups we have, think about that alternating model so that you can ensure that groups are able to participate everywhere, because we do depend on virtual. We also use Slack. There's amazing use of the Slack, and we have lots of asynchronous discussion that happens in there so that people can post when they're awake and answer when they're awake, which may be very different time zones. But then to get to your other point about governance, I think this is a really critical area that I wouldn't say we've 100% solved in terms of how to guide and influence these sorts of policies. I think RUSE is certainly active in that area, but for the product steering committee tomorrow, David Glazer, there you are, brought up starting to talk about these issues around TREs and trusted research environments, so that as these get created by commercial entities, they adhere to a certain sort of set of governing principles. I think the NIF community is a great place where countries are dealing with governing approaches for their countries and sharing amongst them, even if it's not a single standard that GA4GH puts out. The convening power that we have as GA4GH to bring groups together in different forums and share how each has tackled this within their own country, organization, consortium, program. I think we can all learn and make use of that. So, I think there's areas where a single standard isn't the necessarily answer, but that, will really do well to work together. With that, I think we may be we are, or no. Oh, actually, we have 9 more minutes, right? Doesn't it till 9:30?
Yes.
Okay.
I know Slido isn't up on the screen, but we do have a question which I can read. Does GA4GH have any plans for working with standards for value demonstration of genomics in healthcare? For example, methods for health economic evaluation of methods and technologies. This will likely be key for implementation.
Actually, Andy and I were just talking about that at dinner last night. Where's Andy? Do you know I can talk about what Andy and I were talking about.
Rambler.
What's that? Just ramble. So the answer is No, not that I'm aware of, but I'll ramble. No, so actually, Andy and I were talking about the fact that EBI had commissioned an impact analysis of EBI and all of its resources, and showing how much economic growth was incurred from a small, investment of dollars in the resource development at EBI. And we were talking about, gee, it would be really great if GA4GH could do some sort of analysis of that sort to look at, the dollars invested in the work that we do, and then see the impact downstream on lots of different things. It's got to be a very complex project to tackle. And I was like, how much does that cost, Andy? So, but I think that gets at a little bit of this. Now, at the same time, I think there's other health economics questions around just precision medicine and other aspects where these are really important studies to be done as we think about that. But I think what Global Alliance will do itself versus what we encourage our community to do, are two different things. Do you have anything else you want to add?
Yeah, I was just going to say, I think the value statement or the justification. So we've all the conversations we've had, and it's often within the National Initiatives Forum, where countries that have pioneered genomic or precision health have done it in the beginning because they believed it was the right thing to do. It's very difficult in the beginning to show the health economics. As you get up and running, and Sue's dealing with it in English NHS, you have to do. The more mainstream genomics becomes, the more it will be subject to health technology assessment. And so we need to prepare for it as it moves into the clinic. We've probably got a little honeymoon period in the beginning when we can go with innovation and technology, which is very different from the other side of it, that the countries that have really led in this area have really sold the economic argument, the growth of companies and businesses. So you've got this economic of healthcare, and you've also got the building an economy based on the innovation that genomics contain. They're both different sides. Well, somebody's thinking of a really good question. I was going to pick up on the implementation. So Heidi talked about 44 products and the 200 plus implementations. That is ignoring CRAM, BAM, VCF, because if we count those, clearly the implementations are in the tens of thousands of almost everybody has used those standards and continues, in many ways, continues to do so. So the challenge we have with the new things is we often don't know till we come to this meeting that somebody stood up a new version of Beacon or there are different applications. So tracking the implementations, and Sasha's doing a lot of work on that, and she'll be talking more about this, understanding where we've got implementations, where they're working, how we get the feedback loop, and our tech team working on that next iteration that Heidi mentioned. But if anybody is, please share with us what you're doing, what's working, what's not working on the implementation side. That conversation we had yesterday about off-the-shelf versus standards development. So if you're involved in it and in any way you've improved it, you found a different way of implementing it, more cost-effective way of implementing it, tell us, bring it back into our community, and then we can upgrade the core product in a way that helps everybody. Okay. Just saved 4 minutes. Okay, thank you all.
So I'm just going to welcome Kenneth Bailey up, who's going to moderate our next session and introduce our keynote. Kenneth.
Thank you very much. Our next session is about making the case for data sharing. So you're going to hear about how to quantify or estimate the benefits of data sharing, how to align and understand incentives in the real world from some impressive stories of people who've done this. And for our keynote, most importantly of all, we're going to hear about the most persuasive kind of evidence, how to build a compelling narrative for why data sharing really matters. So it's a pleasure to introduce Carolina Vitabäck, who is an advisor to the public sector on data governance and other data issues, and a parent of a child who's been impacted by data sharing. Carolina.
Thank you. Thank you. Good morning to you all. My name is Carolina Vitabäck, and I stand here today as as a parent and as a professional. As a parent of a girl who was diagnosed with leukemia in 2021, and as a professional working with data and information security and information management as well. I will talk to you about what happens when cancer enters your family, because in a moment everything changes. You begin to live 1 minute at a time, holding on to hope wherever you can find it. And this is why I believe very strongly that data is not just numbers, it's so much more. It's stories, it's possibilities, and it's the hope for a future where no parents hopefully have to fear of losing their child, and for the child affected also have a chance to heal and to live and prosper after. I would first like to give you a short brief on the Swedish Barn Cancer Fund and the Swedish Pediatric Cancer Foundation. It's the largest contributor to research for pediatric cancer in Sweden. And just to give you a number on, in Sweden, a child a day is getting diagnosed with cancer. And it's the most common cause of death for children in Sweden as well. More of them will survive today than just 10 years ago, but still 7 out of 10 of those who will survive will suffer from long-term side effects that will affect their life. So now research is focused both on better treatments as well as to give fewer long-time side effects. So I said, my professional work with data and information security has always been about protecting what matters the most. As we said, I've been working a lot with the healthcare sector and also with the public sector, such as municipalities. And we take care of the data that is most precious, most important, and most sensitive. We need to treat that as the valuable asset that it is. But my personal engagement in these questions became even more truly when this became about my own family. So I'd like to start to tell you about our family's journey with cancer, so you can see where I come from and where my commitment is. This is Esther. This is my daughter. In these pictures, she is almost 13 years old. Small powerhouse of a girl, very strong will. I tell you, she has a lot of humor. She has talent in judo and a keen sailor, and she was entering her teenage years with a lot of optimism and joy. And as I said, strong will teenager. But in May 2021, something changed with her. We thought she had broken a rib during a judo competition. Then 2 weeks later, we thought she had broken another one, which was strange. She started having fever, rashes, immense fatigue, pain in different parts of the body, and we couldn't make ends meet. Why was this happening to her? So we started searching for answers. We had, I don't know how many calls to the primary care center, trying to find out what was wrong with her. And we always get the same answer. It's probably nothing, probably tired, she's in puberty, her ribs are hurting. Just ignore it, it will pass. But still, it didn't add up. So as parents, we try to stay calm, but if you have kids, you know that even you stay calm on the outside, on the inside is a turmoil. Fear just kept rising. And in June 2021, one late night when I tried to help Esther, she said, "Mom, I really feel that something is so wrong in my body. I think I have cancer." And that gave me a shock because I didn't understand where that came from. I still don't know. But I assured her, there's nothing to worry about. It's your ribs, you know that the doctor said so. But still, my mind was just working in overdrive, like, okay, something is really wrong here. I have to find out what it is. And then the turning point came 2 days after her 13th birthday, a birthday she spent in a lot of pain and a lot of fever and didn't want to do anything. One night she started screaming from her back pain. And after a while, she couldn't even breathe. She was in such pain, so she was just static. So we rushed into the hospital and we were admitted immediately, where they put her on morphine and sent her straight to X-ray. The X-ray showed that her internal organs were swollen, but it couldn't tell us why. But the blood samples didn't look good. So the morning after, we were rushed in an ambulance to the pediatric oncology department in Lund, that is in the university hospital in the southern part of Sweden. And I can tell you that ambulance ride was awful. She was almost unconscious from the morphine and the pain, and I was just petrified with fear because somehow I knew where we were going. From the ambulance, she was rushed straight into anesthesia and then the lumbar puncture for testing. This is a child who's never been in hospital except for the day she was born, so this was a huge shock for all of us. A couple of hours later, we were given the initial diagnosis. They said she probably had leukemia, and an hour later they started with the chemo. This was the worst moment in my life up until that point. And the next day, Esther had a port implanted to get IV straight into that. And within days, her body started reacting to this huge flood of medicine. She had chemo, she had antibiotics, she had steroids, you name it, she had it. She had pills, IV drips, injections. And all the time she was in such pain. And apparently this was because all the cancer cell had collected in her internal organs, making them swell, making them push her ribs and her back and her lungs. That was, she was in such pain and she had so much trouble breathing. During this time, she was so ill and she was so afraid. And we quickly understood that this was not going to be a short stay. The treatment was supposed to last at least 2.5 years, if it worked. And the hardest truth of all was that the doctor couldn't give us a prognosis. They said, well, we probably could cure this leukemia, but the treatment itself is life-threatening, so we can't give you any guarantees. During this time, I didn't know how to get through this. I just wanted to save her. I just wanted to pick her up and run away from there, but I knew I couldn't take her a meter from the hospital because then she would die. Another parent told me, it's like, you can't look at the whole journey. It will make you crazy. Try to look just a step at a time. Someday you can look at a day at a time. Sometimes just an hour at a time. Sometimes it's 5 minutes. And when it's unbearable, you just see a minute ahead. And that really carried us through her treatment. We spent months at the hospital. It became our second home, truly. We had planned stays, of course, for treatments, and we also had a lot of unplanned treatments at the hospital. This was going on for 2.5 years. The planned stays, there was the treatments, was x-rays, biopsies, ultrasounds, MRs, spinal injections, pain management, wound management, the list goes on. And the unplanned was mostly because of fever, because her immune system was so low. Every time she had a fever, we had to be in the hospital within an hour for antibiotics in an IV drip. Otherwise, she had a huge risk of developing sepsis. So for a month, I remember we went into the hospital 11 times unplanned. And you can imagine what that makes to us as a family. It took a huge strain on Esther. She was dead tired, so much in pain. She just hated everything about this. And on Esther and her little brother, of course, because we were always away, always worried, always going back and forth to the hospital. And also to us as parents. And as Esther so kindly, as I said, she is still a teenager during this phase, told me one night in the hospital, said, "Mom, you look so much older now than you did before I got ill." Like, yeah, that was, I can tell you, I did. But what carried us through, truly, was the extraordinary staff in the cancer ward. I mean, unbelievable. They hugged us, they fought alongside us, they explained everything, they comforted us and Esther. I mean, we owe them everything. They were just amazing. But at the same time, we were going through moments of despair. I had to listen to my 13-year-old daughter planning her own funeral. I had to listen to her begging for us to stop treatment and just let her die because we couldn't take it anymore. I had to watch other children walking through the ward looking like small ghosts, and to see that a few weeks later they weren't there anymore. They had passed away. We had nights of fever, but it just kept rising. She had been given every medicine they could, but they couldn't do anything more. And I just had to swab her with wet towels all night while she was crying because she didn't want it. She was in so much pain. I was holding her hand while she was unconscious due to heavy medication and pain. And these, by now, were definitely the hardest moments of my life. But yet somehow, with the support we got, both from friends, family, and, as I said, extraordinary staff, and also that Esther's resilience, we managed to move through this, one day at a time, sometimes just a minute at a time. And during this time, we were given a wad of papers. We had to sign to agree to give collect Esther's data for research. And on the one hand, when you're so dead tired and worried, just to read all that text, it's impossible. We didn't know what we were reading, but we were grasping for hope. So we said, fine, we sign anything that could help her. We're just going to sign it. And then we have to deal with the consequences if there are any. Esther was actually quite lucky. She had acute lymphoblastic leukemia, and luckily her treatment could follow something called the Altogether protocol. It's a well-researched treatment plan that personalizes therapy based on the risk for each patient. So for the low-risk patient, they will receive a less intensive treatment to try to reduce the side effects. And for the high-risk patient, such as Esther was, you will have a much more intense treatment to avoid a relapse later on. The risk stratifications guided every choice, and that felt very good, I can tell you, that we knew that, yes, she was giving something that could kill her, but they only gave it because they saw it was really, really necessary just for her. And the goal for this protocol is to improve survival while trying to reduce toxicity. And time again, this treatment had to pause because the doctor said there's about 200 side effects when you go through this treatment. And I can tell you she had a lot of them. But so then we had to pause the treatment, and that created panic within us because will the cancer start to grow again if they have to stop? And then the doctor told us, like, well, there's no straight line in cancer treatment. It will go like this, but we'll still follow a line. You can be sure that we'll do everything we can until we're standing on the last line and we can say we did everything, but it didn't work, or yes, we did everything and it did work. Some of the side effects that she suffered, well, altogether is a life-saving protocol. And as I said, we're truly thankful and grateful for that, but it takes an enormous toll on the body. As treating children with cancer, you're not only supposed to treat the cancer, you also have to treat the cancer with minimal effect on other things apart from the cancer. These are children that are still growing. Their muscular systems are not developed. They want to have kids in the future. It takes a lot of different decisions to treat a child with cancer than it does for an adult. Well, you can see here is a small menu of the things she had. And I can't tell you how much of this were, this was just awful in every way. She had organ toxicities on a number of occasions. She had 2 acute pancreatitis twice due to treatment, which also gave her diabetes. She had organ damage. She had neuropathy, so she was couldn't walk for a couple of weeks, and that still gives her a lot of pain in her back and her legs. She had seizures, brain toxicity, hallucination. She had anaphylactic shocks when she couldn't breathe, and we just had to stop everything, and the Q team came in and helped her. She had a lot of steroids that changed the mood, that changed her weight. It makes her bones fragile. And we had some funny stories about this, because when you get a lot of steroids, as I said, it changes the mood. So all of a sudden, your really tired, sad little girl turns into a monster, screaming things at you, words that you didn't even knew that she could tell. And then we also had, so me and another teenage mom, we developed a system because our rooms were close to each other. So we knocked on the wall when we need to go out into the kitchen and cry a bit and just have it out with each other. You find your own small survival strategies during this time. She had a lot of pain all the time. This pain. So she went on morphine for 3 years to make her live through this. Her teeth were damaged, and she also developed a severe depression, so she even attempted suicide twice. And all this, just the side effects to keep her alive. And she's still struggling with a few of them. She had peripheral neuropathy, that's a very difficult word. She has pain in the back and the limbs, and she also mental fatigue, and she also struggles a lot with PTSD still. But she and we made it. This is Esther in her boat when in the middle of treatment when life was shittier than ever and she didn't want to take any more pills. She just wanted us to stop everything. What do you do as a parent? You pull out the bribe. So we pulled out the bribe. We said, we're going to buy you a boat if you start to take these pills. If you do everything the doctors tell you, we promise we'll buy you the boat. So we did. We bought her the boat. And the boat name is Manuel, after her favorite nurse at the ward, a Spanish guy, truly amazing, who could meet her at her level. And when we couldn't talk her into doing things, he did. So we owe him everything. She still has a lot of side effects. She has scars, both visible and invisible. So to say that she made it doesn't mean that the struggle is over. But it means that she survived the treatment and she came through the storm and she can still thrive in her life. But it also means that data and science and medicine and the courage of this small powerhouse actually worked. It gave it a chance to grow up, which we wasn't sure about in the beginning. And for us as parents, I mean, if you are parents, this is gratitude beyond words, because to the healthcare teams, they never gave up. Never. Even in the darkest moment, they're like, we're going to fight. So you can lie down and give up if you want to, but we're not going to do that. And I can tell you that helped us a lot. And also to the research that we have read up a lot after, how the protocol is developed and how it's emerged thanks to research. And also, like I said in the beginning, to every data set. For to me, every data set, every trial, every patient before her who suffered has made her survive. So when I say she made it, it doesn't, you can hear the relief of a whole family and a lot of other families at the same time. Because this means what precision medicine actually can do in real life. And by doing that, I'm going to keep on to the next part of my speech, because our story is very personal, but of course it's not unique, unfortunately. Behind every story like Esther lies the same truth. Children's lives depend on data, on science and collaboration. And that takes us to this second part, when data actually means hope. Because today's treatments, as I said, they save the most children, but the journey is still very long and very painful. And we need better risk stratification, so every child only gets that much treatment that they actually need. That means fewer toxic side effects. That means better outcomes, and also that we can put in target therapies much earlier in the treatment that we can do today. We can also see we can only understand these rare subtypes that child cancer actually includes. And that can only be done through shared data and joint trials. And to make this possible, we have to strengthen the foundation where we collect, manage, and protect research data. So just looking at your introduction is like, I get all warm. It's fantastic what you do here. And that's also where the next challenge begins, the pediatric cancer research. Because pediatric cancers are rare, which we are very happy about, of course, but they're also very diverse. It's a very small patient group, not just size-wise, but also to the number, which makes research a bit difficult. So data quality and security is even more important when it comes to this kind of data. Because if the data isn't accurate or complete, the progress slows and the patient will actually suffer. So we also need to address the protective sensitive patient data. And as I said, I work a lot with cybersecurity, information management, and the cyber threat landscape today is fast growing, and it's very terrifying when you look into it. So we need to make sure that this very sensitive data is handled in a safe way. So therefore, ethics and consent must always guide us in what we do. But despite all the progress we have made, a lot of challenges remain, and we know that just collecting data isn't enough. We also need a breakthrough in how we handle the data. As I said, for cancer in children, we see that fatal outcomes are declining, but we also see that also means that the one who survives will have a lot of side effects that they'll have to live with throughout their life. So now we're looking into, we just don't want them to survive, but we want them to live and thrive afterwards. Because there's a lot of hidden costs with cancer survival today, both for adults and for children, but the children will need to carry those side effects for the rest of their lives, and they will affect them. No matter how big they are, they will affect them. And that's why we see that we need to find the treatments that can both address the side effects, but also are kinder and safer to the child during the treatment. There was a lot of talk about AI. I'm sure you all heard this. And AI by far is not the solution, but it's part of the solution, definitely. And we can also see that data and AI can help us see things that we didn't see before, because they can reveal new tumor types faster and they can predict relapse risk. And for someone who has battled leukemia, the relapse is a constant fear every day. So we feel that every day Esther is healthy is a day closer to even better treatment if relapse should happen. And step by step, data and AI can together turn complexity into clarity, and by that also hopefully better treatments. I have a few pictures left. The brainchild, just this is an example that the Swedish Child Cancer Fund is sponsoring. We're creating a national platform for centralized AI data ready data for pediatric cancer. And it aims to connect genomics, clinical and other data in order to make this interoperable and patient engagement, and to make this accessible for research around the globe. So Brainchild is just one example on how national collaboration can move us forward. What you do here, as I said, that's amazing because that's exactly what is needed. We also have a new framework regulation coming in the EU, the EHDS, but also we had a lot of other large organizations sharing data. And what's so impossible is that childhood cancer doesn't stop at borders. It's all over the globe. So we need to have the global collaborations in order to make the treatments better and safer. So I believe that progress doesn't happen in isolation. It happens when we work together. So from research and clinicians to families and patients, everyone can play a part. Because when data is shared safely and used wisely, every contribution can become meaningful, and every discovery can build on another, turning data into knowledge and knowledge into life. Because in the end, the shared data actually means shared hope. So, during the darkest moments, we learn to live 1 minute at a time when needed. But now we can actually look a bit forward. This is my family in May this year. That is Esther with her hair back. Very happy about that, I can tell you, as a teenager. And during this time, and that's why also I'm so committed to this issue, is that we have seen what research and the access to data actually can do for survival. And we met a lot of other families during our treatments that wasn't so lucky as us. So for them also, I like to stress the importance of what you are doing here, because every bit of knowledge will help in some way we build on with others. So just to say that I just want to thank you all for your hard work and your colleagues' hard work, because you are truly saving lives in one way or another. Maybe not today, maybe not tomorrow, but in a few years' time. So from the bottom of my and my family's hearts, thank you.
Carolina, that's a wonderful story. Thank you very much indeed. It was very difficult to tell and difficult to hear. While the audience recover, we'll take questions for 10 minutes if you're willing.
Yeah.
Can I start by taking you back to when you said that you were given so much paperwork to read to consent to participate in research studies and data sharing? Where I think we can all, from the vivid story you told, we can all imagine a bit what that was like. Could you tell us a bit how do you feel consent really works in that context? Is informed consent even possible, and is it reasonable to hand over that much paperwork to a parent in those circumstances?
Yeah, I think that in one way, we, as I said, we completely understood that the need for her data, and in the desperate moment, we were just thinking, if we sign this, maybe they find something new that can help her. That was how my mind was working during that time, because I couldn't read that through. I didn't even understand the first page, and I read a lot of reports and stuff every day, but that was just mumbo jumbo to me. So what I think would be helpful is maybe a short, I don't know, video or something like 1 minute, because that's probably all that you can take in. And also that really points to the importance of this may not help your child, but it will help the children following your child. So please share your data. I think that would have been more helpful, because I understand that we have to read through all these papers, but I did that like a year ago because I couldn't do it at the time. And also that reading through that, you also read about the risks of things. You read about if you consent to data, you can also be subject to trials if you want to. And if you're subject to trial, yes, that could help, but it could also hurt. And you can't take that in at that time.
We'll take a question from the audience. So the top question is, how does childhood cancer prevalence in Sweden compare to the rest of the globe, and what accounts for Sweden's relatively higher success rate?
Yeah, I couldn't say about the prevalence compared globally, because I'm not that, I don't have that knowledge. But as I said, the Swedish Childhood Cancer Foundation has actually made a huge difference in Sweden, both in research and also in treatment, because the money that we collect, they go half of it, more than half of it goes to research, straight into research. And the other things go into support at the hospital, support for the families, support for the staff. So when you're getting your diagnosis, you will also get a lot of support in the areas around, and that also will help. I can just tell a very short story. We have something called like the support for siblings, which the Cancer Fund finances. So when Esther was in a very critical time during her treatment, her little brother's 10th birthday was coming up, and he has been put aside for months. And he's just said that, I would just love to celebrate my birthday. I just need a day, but could that be my day? Because my number is now 10. So could we just celebrate me? And we said, of course, we have to do everything to make this happen. But of course, Esther had a fever the day before. She was acutely admitted to hospital, and we could just see this whole celebration going down the drain. And then the sibling supporter called us, and she said, hi, I heard that you were admitted again, and then it was Kalle's birthday tomorrow. I prepared a little party at the hospital. I bought some gifts, I got a cake for him, and the staff will join me and we'll sing to him. And I can tell you, I guess me just talking about it. But during that time when you're so tired and desperate and sad and feel so bad for this little guy who's striving to help us, that he had actually a small birthday party. And all of the staff came out and sang to him and celebrated him. That was amazing. And you were also talking before about the economic effects of this. The effects for him and for us, it's hard to put a financial number on it, but I think that if we get also access to things like that, we can do more. We don't get as tired. We can help the staff more and everything. So that was just amazing.
Sorry, I'm sure everyone in the audience has a lump in their throat hearing you talk about it. I'm certain no one here is going to forget your story. The next two questions allude to really the same thing, which is, are there elements of Esther's journey where you can see an impact from data sharing, either one that was real at the time or one that's potential for the future?
I'm not sure about the future, but I can say that when you get diagnosed with acute lymphoblastic leukemia, they make, and I don't know the clinical terms, so, but they make a genomic analysis of our cancer cells, and that will decide what kind of treatments you will have, because this ALL protocol goes in like 5 arms, they say, depending on what type of risk. So that will decide which kind of treatments you will get. And the further we go, because they say Esther developed pancreatitis twice, and that made that she couldn't have one of the very effective medicines for relapse. And then, well, that gave us a slight panic, I would say. But then they said, well, we have done another genomic testing on her, and we see that she's probably not that high a risk for a relapse. So if that happens, we have a plan due to this and this. And we know that in the next year, we will know even more due to research. So just hang in there.
It's difficult to overstate the authority with which you speak and will be listened to by society and the government. So your answer to this question, I think, will be very important. When is consent relevant? If whole genome sequencing is introduced in Sweden, and it has been for all pediatric cancers since May 2024, when should consent be sought for whole genome sequencing?
Oh my God, that's difficult. That's very difficult. But I think probably as soon as possible, during the treatment, even though if I'm now answering it correctly. Because I think that if you can address it with, as I said, the hope, like if you agree to do this and share your child's data, you can help your child and you can help other children, as it also makes research progress much faster. And that was what we're thinking, and that was what we're discussing with other parents. But it has to be presented in a way that you can listen to and understand when your mind is elsewhere, because everything they told us just went straight through the ear the first month.
Do you think like a staged approach to consent, where people could initially consent to very basic information, and then be given more information later?
Definitely.
Yeah.
And also, as I said, talk about, because now you get a very clinical approach to it, which I understand is important, but as a parent, you don't understand that. You just want to, what happens to my child's data, and what will it do for my child's recovery? That's the only thing you're interested in at that point.
Yeah. We have a few more questions. Many of them are saying thanks to you, which I can guarantee you is the overwhelming mood in the room. So could you tell us, are you aware of any other research patient and parent experiences that are like these that have ever been collated as a research project, either in Sweden or elsewhere?
Yeah, I have a story. We, as I said, when we were in the cancer ward, you get to know the other families and the patients a lot, because you see them at every stage during 24/7. You're tired in your slippers, you're crying, you're happy, everything. There was a small guy there called Edward, who was 5, and he had a brain tumor. And he was treated with the standard setup of chemo and radiation, but it didn't work. So in the end, it was like, we don't think we're going to help him. He's probably going to die. And they were talking about going into last care for his last day of his life. But then the family was asked if they were prepared to try a new medicine that was in trial, because they had nothing to lose. So they did. And he recovered. He now takes a pill 1 time a day. And this was a child who was supposed to be dead a year ago. That's amazing.
Yeah. Your journey obviously had like lots of moments that would change your opinions about lots of things in life. So one of the questions here I think is quite insightful. Can you remember how your opinions about consent, data sharing, and research have evolved during the course of your journey?
I think that I've been more interested in it, and see more and more the need for it. And that's why I feel almost like a desperate need to help whenever I can, because I've seen, if Esther had been sick 10 years ago, she wouldn't have made it.
Yeah.
And that's what we always in the back of my mind. It was like, she would be dead now, but she isn't, she's here. So, and if you look at it like that, when you came a bit through the worst part and you could start to see things more clearly, then it's like, whenever I'm through this, whatever I can do, I will do to help. Because, to us, it's obvious. It's the life-saving.
Telling your story helps an enormous amount. It's incredibly persuasive, and I think people who can imagine as best we can going through what you've been through, I think would quickly be persuaded of that themselves. Do you find that when you start to tell your story, it's difficult because people know what's coming?
Yeah.
They know it's going to hurt. So if you're talking to politicians or people in the public sector about the advice you give, do you find it's difficult to start to tell that story? Do you notice people try to back away because they don't want to suffer with you?
Sometimes people do. Mostly, I would say politicians, clinicians, and others are used to it. It's more or less so they don't react. And for politicians, might try to back away and hide behind, well, this is the regulation system, and this is that, and this is that. And to me, I think that it always helps to well, if you put the patient here, she has a name, she looks like this, she likes to do this. It's much harder to try to shy away from the things we are talking about.
Yeah. I think we could all listen to you all day. We've got a few more talks, none of whom I envy taking the stage after you.
No.
But can we finish on probably the most relevant question, the one at the top there? Where do you envision GA4GH being most useful in this space?
Well, as I said, when I looked at this circle, it gave me goosebumps. I was like, yes, this is it. This is the thing, that we collect data, we use it globally. We have all of these different partners and founders working to creating products and everything. To me, it's just keep it up. This is amazing. It's truly amazing.
Oh, thank you so much from all
much.
of us for sharing that with us. I know it was difficult and it was tremendously useful to listen to. Thank you very much indeed.
Thank you so much.
So, with the very unenviable task of taking the stage now to talk about more dry but very relevant topic, how we actually take narratives like that, evaluate the cost and benefit of the things we're trying to persuade people to do. I'm delighted to welcome to the stage Lauren Maxwell, who leads a research group at the Heidelberg Institute for Global Health and is an expert in epidemiology, data science, and qualitative research. Thanks very much, Lauren.
Great. Well, thanks everyone. I didn't bring tissues, and that was my mistake. But I'm sure others have made similar mistakes today. So we are talking about how do we measure the cost, benefits, and harms of biomedical data and sample reuse, and this speaks directly to the last talk. So thank you for opening. Although I cried before my speech, so it's the first time crying before a speech, and also the first time at GA4GH, so very nice to meet you all. In terms of our problem and what we have here, so I think everyone in this room, and I'm really speaking to the choir, is very aware of the benefits of biomedical data and sample reuse. And those benefits are obvious to us, but they're not obvious to policymakers. They're not obvious to health systems. And they're not obvious always to clinicians themselves. And so we have to really think about, why is that the case? And part of it is because we're not doing a good job of measuring the cost, benefits, and harms of data reuse, or of not reusing the data. And so what happens, and I really like this quote, so I put it here, but I'll let you read it yourselves, is that in the absence of a clear demonstration, we're really focusing on the hypothetical downsides of data and sample reuse. And so I challenge anyone to come up here and make me cry with a story about the harms of data reuse in childhood cancer. If anyone, please take the stage. I think that would be very difficult. So yesterday we heard about a famous Uppsalan and what they had to say about health data. So today you're going to be learning about another famous Uppsalan and what they have to say about health data. So this is Hans Rosling, who many of you may have heard of. So one of the things that Hans said that I think is relevant today is that when things are getting better, we often don't hear about them. So what happens when we don't hear about the good things is that we have a systematically too negative impression of the world around us, which is very stressful. So if we think about the legal landscape and how the laws align with the priorities for patients and for citizens, we see this lack of alignment, and we see a focus of the laws on the harms, and we don't see a focus on the benefits. So no one is going to go to jail because they didn't provide benefit from health data reuse, but they will be, you heard from this very frightening example from India that possibly people could have criminal penalties from using health data because of these perceived harms. So we need to do a better job. So one of the things that we've done is set up what's called a scoping review to try to understand how are we measuring the costs, benefits, and harms of data reuse and the lack of data reuse. How are we measuring the cost savings? So you can see here what we've done, and we'll go through it relatively quickly. So what we wanted to understand is what are the costs, benefits, and harms of reusing the data or of not reusing the data? How are they measured? What types of comparison groups and methods are we using to measure these? And then for what types of data, for what populations, for what disease areas, in what contexts or situations, and for what stakeholders in the funding to impact life cycle are we measuring these costs, benefits, harms, cost savings. So this is just a snapshot of what we found. And what we found is that a lot of these studies are focused on the benefits. So we could see why. We are all very interested in the benefits. So you'll see some kind of limited information about the harms, but when we're thinking about the harms of data reuse, we're thinking about the harms to investigators, because obviously investigators are key stakeholders in the data reuse landscape, and they're very concerned about the harms of data reuse. But there can be other groups that are concerned about the harms of data reuse. So I work in emerging infectious disease, and in that space, governments are concerned about the harms of data reuse and data sharing. So we need to be conscious of that. Another thing that you'll see is that a lot of these studies don't have comparison groups. So as an epidemiologist, if you come to me with information on health and you don't have a comparison group, then I would, have some questions. So we want to think about how rigorous are these studies, and then we want to think about how are these measured. So you'll see some studies are using bibliometric measurements, some studies are using descriptive analysis, other studies are using simulation, and some studies are not going in and looking at the costs, specifically at the costs or specifically the harms. They're neutral in their approach. And some studies are using a mixed method to look at the cost, look at the benefit. The cost studies are really based on simulations. But again, you see more of a focus here on measuring the benefits. And measuring the benefits is very important. And honestly, I think we're all here to measure the benefits. But I'd like to go back to what Hans Rosling would say. So this has to do with the idea of if you have a good idea, just stick with it. Don't vary. So you'll hear a lot of Hans Rosling today. So he would say, test your ideas. Don't only collect examples that show how excellent your favorite ideas are. Have people who disagree with you test your ideas and find their weaknesses. So one thing that's very interesting is this idea that we need to do a better job of conceptualizing the harms of health data and sample reuse, and we need to be more honest about what those harms are, because if we can be honest and transparent, perhaps we can show that the benefits really do outweigh the harms. So this is one of the studies that we came across where it's a European-funded study looking at what are the costs of not reusing the data. So we need to think about what are the costs of enabling the reuse of data and samples. And then we also need to measure what are the costs of not reusing the data and samples. And we can think about conceptualizing that cost in different ways. So here we see that there's a cost to Europe of over 10 billion a year of not using data effectively. So again, what would Hans Rosling say? So Hans Rosling talks about factfulness and really recognizing that a single perspective can limit your imagination, remembering to better look at problems from many angles to get a more accurate understanding and find practical solutions. So he says, get a toolbox and not a hammer. And part of the issue here, so this is not meant to be a legible slide, it's meant to say that we have many different stakeholders in the funding to impact life cycle. And what that means is that we have people who have different kind of value systems, different objectives. And we heard this really nicely yesterday when our colleague said, the people in the hospital are concerned about getting people out of the hospital, and not concerned about data reuse. So we can't assume that people are kind of, have the same incentives that we do. They oftentimes have very different or contrasting incentives, and we need to be aware of those incentives and measure them and measure their impact on data and sample reuse. So a few key points that are come out of our work are that attitudes about and experiences of benefits, harms, costs, and cost savings are heterogeneous. They're influenced by context, including the group that the data are shared with, the data type, the disease area, population, and the purposes for the data reuse. So we also heard yesterday that not all industries are considered differently. So if you're sharing with a social media company, that's very different than sharing with a medical SME or a for-profit pharma company. And then we also found that the convergence of key themes across studies, disease areas, and geographies or populations, including the importance of benefits, clarity on data governance and future use, and data sovereignty, signal key concerns that need to be addressed through policy and regulation. So what we see if we look across kind of applied ethics work in the data and sample reuse space is we see a lot of commonalities. So we think about differences, but there are actually a lot of commonalities. So again, what would Hans Rosling say? He would say, look at the systems, not the heroes. So who in this room is not concerned about the harms of health data reuse? So we heard from her yesterday. Turns out that the Estonians are not terribly concerned about the harms of health data reuse. So why is that? That's because they have immutable and transparent provenance metadata. And they have a clear community-developed data governance framework. So when you have these things in place, you don't have to be concerned about the perceived harms because you can see the harms. They're transparent to the population. So how did they do that? Was that, a miracle that fell from the sky? What happened in Estonia is that there was a blank slate and a very limited or not very limited, but a somewhat limited economic, let's say, pocketbook to fund this. And so people really had to come together and think about what's the best system to deliver value to the most stakeholders. So we're not talking about one stakeholder group. We're talking about a multitude of stakeholders that are involved in the funding to impact life cycle. And that's what they did in Estonia. And so now many of us are faced with a choice. So some of you may have ridden the New York Metro, and some of you may have ridden the Mexico City Metro. These are both massive cities. They have massive heterogeneous populations. They have many, complicated kind of priorities. But the metro systems look very different. So if you've ever had the pleasure of riding on a Mexico City Metro, you would know that you're going to be able to get to where you want to go. But if you've been to New York, and New York is a wonderful city, you're going to know that you need help from other people. So you're going to have to bring together people to get to your destination. And that's a choice that we have when we're setting up these systems. So a key message that I'd like to deliver is that provenance metadata is central to trust. So it's not the only thing. We need data governance, but we really need to work on the provenance metadata challenge. And we're here for data reuse. We're here for interoperability. We're here for metadata, but we really need to think about what is the endpoint? And the endpoint is impact. The endpoint is not, the data reuse. The endpoint is the impact, and we've heard about that today. And then just really briefly back to Hans Rosman. Hans Rosman said the world cannot be understood without numbers, but the world cannot be understood with numbers alone. And I think that our last speaker, Carolina, did an incredibly powerful delivery of why that is. So I'm not going to make you cry with an epidemiological graph. It's not possible. But I will say that I started as a qualitative researcher, and I moved to quantitative epidemiology because people wouldn't listen to other people's stories. They listen to the numbers. And that's unfortunate, and I don't know why that is, but we have to work in the system that we're a part of. And then I'll also bring up another quote about the inability to understand statistical information. It's not a mental deficiency, rather it's poor presentation of the information. So we need to think about how are we presenting these, and just inspired by our colleague from Estonia, if my birthday were this week, I would say, can we have Gapminder for biomedical data review? So Gapminder is something that Hans Rosling invented to try to think about how can we address the misconceptions that people have about things that they take to be fundamental truths. So I encourage everybody to look at that. And one of his key points is that if we use data, then we can really think about avoiding being stressed about the wrong things. So in health data reuse, biomedical sample reuse, we need to be thinking about the right things, which is building health, and it's not thinking about perceived harms that we have no data to support. We need to effectively measure the harms to say that there are no harms so that people can really trust what we're saying. So I'll end with that, and many thanks for allowing me to go a minute over, whatever that was.
Thank you very much indeed for taking that challenge and soaring with it. We'll take questions during the discussion section at the end. The next talk, unfortunately, due to circumstances out with our control, our next speaker, Hwee Lin from the National University of Singapore, is not able to be with us in person, but will join us online. She is Associate Professor at the Director of the Centre for Health Intervention and Policy Evaluation Research. She's going to advance our understanding of how to make the case for data sharing by grounding the discussion in cost-effective analysis in practice in the real world. Thank you.
Thank you. And thank you to the organizers for this opportunity to share. I'm sorry that the inclement weather affected my flight into Sweden. So I'll get started. So maybe you have attended the plenary session and already know about our National Precision Medicine Program that was shared by Prof. Patrick Tan yesterday. But I think I'll talk about it a little bit today as well for those who are not able to attend the session. And I will be sharing about what payers in Singapore want to know when it comes to implementing a population-based health service. And then I'll cover how we would generate the answers that the payers want to have, and then emphasize the importance of data sharing. Yeah. So precision medicine is one of the key goals of Singapore's Research, Innovation and Enterprise 2025 vision. Yeah. So what you see on the globe there is a picture of where Singapore is. We're a really, really small island city. And the strategy is intended as a research roadmap to accelerate biomedical research, improve health outcomes, and enhance opportunities for economic value across sectors. And all of this work is coordinated by Precision Health Research Singapore, or also known as PRECISE. So our National Precision Medicine Program is organized into 3 phases. We have just completed phase 2, where we collected data on 100,000 healthy Singaporeans and 50,000 people with specific diseases. I shall refer to this as the SG100K later on during my presentation. And we're moving on to phase 3, where we hope to implement precision medicine in Singapore on a larger scale. And this is what we are referring to as scaling up at the population level. So I'm going to run through the next 2 slides really quickly. They are not meant for circulation, but I just realized that we're on YouTube. So I want to mention that in Singapore, for the Ministry of Health, we have a framework, a program evaluation framework, which is integrated into our policy and resourcing cycle so as to provide a resource performance feedback loop. So in general, before any program is officially launched, there is a need to define the outcomes, and the outcomes are organized according to short-term, mid-term, and long-term. So for the short-term outcomes, they are reviewed and used to refine and improve program implementation. And subsequently, when we move on to the mid-term, we use the outcomes to make evaluation-informed decisions to optimize resource allocation. At this juncture, there may be a go, no-go decision as to whether the program will continue in its current form. And of course, we hope for the scenario where all the programs that were selected for mainstreaming actually will continue to stay on and translate into longer-term outcomes. And these longer-term outcomes are also being measured to ensure that we're contributing to a healthy population and that the right people are receiving the right and good quality care at the right time. Overall, it has to be sustainable, both in terms of cost as well as the workforce ability to manage the program. So I'll just talk through that. I can't flash that particular slide right now. So essentially, we divide our programs into 2 groups. So Group A programs are those that exceed a certain budget. And for that, it has to undergo a rigorous and formal program evaluation process. And then we have another category known as the Group B. So for the Group B programs where the budget impact is lower, they will actually undergo a less rigorous, but it doesn't mean it's not rigorous, it's just less complex program evaluation. And there are certain programs that fall in between. So for instance, if there is a program that intends to tap on our national savings account, known as MediSave, or our national health insurance program, known as the MediShare Life, then certain policy divisions may request that these programs be treated as a Group A program and undergo a rigorous evaluation process. So when we talk about evaluation, one of the analysis that we would do is what we refer to as cost-effectiveness analysis. So what you can see here is a couple of cost-effectiveness analysis for pharmacogenotyping. So the use case that I am referring to in my presentation today. And essentially, it is to inform the choice of drug gene pairs that should be allowed for reimbursement when it comes to pharmacogenetic testing. And so far, only one particular drug gene pair has been approved, and it is considered the standard of care, and that's the HLA-B*1502 genotyping among patients with newly diagnosed epilepsy. This is prior to initiating carbamazepine. And all the other drug gene pairs at the moment has not demonstrated cost effectiveness. However, my team is making the argument that perhaps we should move away from evaluating one single drug gene pair at a time and move towards the economic evaluation of a panel test instead. And we have got a paper under review that shows that indeed this approach, if you put the correct combination of drug gene pairs onto the panel, it will turn out to be cost effective. So in phase 3, we're exploring using whole genome sequencing for the purpose of pharmacogenotyping. Maybe this might also turn out to be a cost-effective option. So we're evaluating that as well. And to go through the typical components of a cost-effectiveness analysis to illustrate the kind of data that we need. So typically, we would have to emphasize on the local cost inputs, to reflect the way that treatments are medical conditions are managed locally. So in the context of pharmacogenetics, we're also looking at local data, ideally, on the prevalence of normal, poor, and intermediate metabolizers, right? And all of this information, the patient characteristic, cost, and effectiveness, will then be put into a computer simulation model. It can be one of the 4 listed there, or it can be a combination of 2 or more. So for instance, we would use a Markov cohort model very commonly for the purpose of doing cost-effectiveness analysis of pharmacogenetics. And the usual practice is that we would use whatever data that's available, already published, but the challenge would be that most of these data are not representative of the Asian population. And the challenges also include that perhaps different drug combinations are used in Singapore versus other countries. The way we manage adverse drug reactions may also be different. And one other challenge is that a lot of these studies actually do not provide granular level of details. And this points to the need for us to reach out to the original investigators and requesting for data sharing. So, and for those who have gone through this process, you will realize that most of the time you actually don't get a response, which is really, really disappointing. Anyway, so we have an exciting opportunity now to actually link up our SG100K data with electronic medical records data in a platform known as Trust. So what is Trust? It is a data hosting platform that observes the 5 SAFE framework in order to ensure safe, secure, and fit for purpose data sharing. And this is currently managed by our Ministry of Health Trust. MOHT, sorry. Ministry of Health Translation Team. So it is somewhat similar to the GA4GH framework for responsible sharing of human genomic and health-related data. And the principle is that we want to be respectful of the people who share their data. We want to use the data meaningfully to advance research and scientific knowledge and to promote health well-being and the fair distribution of benefits, as well as to foster trust, integrity, and reciprocity. So these are the foundational principles of the GA4GH framework. And coming back to the components of a cost-effectiveness analysis, right now, with the merging of the data, we can use individual level pharmacogenetics data from SG100K to link it to individual episode level health services utilization. And what this would allow us to do is to actually say that for patients with a certain genotype, what can we do? What can we know in terms of how much healthcare they are utilizing? So we can also use that information to find out about the incidence and prevalence of adverse drug reactions associated with a particular phenotype. So this is a research proposal that we have put together. The overall aim is to establish the most cost-effective approach to implementing PGX panel testing at the national level. And aim 1 is to look at the association between the PGX variants and drug responses, because we would have access to drug level data. And we are also able to examine the association between the variants and the adverse drug reactions. and subsequently then to, attach the cost of doing so and to evaluate the cost effectiveness as well as budget impact of having such a test available for the patients. One of the other aims is to use the data that is given to us to discover new pharmacogenetic variants that may be unique to Asia. So I'm using this to illustrate because I am originally not part of SG100K. And therefore, I am very grateful that the research team actually allowed us, like they were very generous in sharing the data with us. And I want to highlight how important this is in terms of advancing knowledge. Yeah. So this is the kind of data that we can have in the TRUST platform. We would have access to claims data. So this would provide the cost information that we need. We will have information on diagnosis. So this will be in the form of ICD codes and also SNOMED codes. Yeah. So there was a mention of Odyssey in one of the presenters' earlier slides. And our system is in the process of mapping to OMOP. So that there'll be more standardization in that regards. And what we have done so far is to output the list of drug gene pairs of interest over here. So this is a subset. If you're interested, I'll be happy to share more, reach out to me via email. And so based on the list of drug gene pairs of interest, we will be identifying the adverse drug reactions associated as they are reported according to CPIC and also the DPWG guidelines. And on the basis of that, we have curated an initial list of adverse drug-related hospitalization costs. And so we will be reporting this shortly. Hopefully this will be useful to some of you in your future work. And basically what we have done here is to identify the adverse drug reactions based on ICD codes. It's not perfect. It's the first cut. In the next phase, we're going to use large language model, text mining, to help us to identify the adverse drug reactions more accurately. And then we also were able to attach the cost, procedural cost. So it's not just the management, but also certain procedures that were performed, such as coronary angiography, as a result of patient experiencing ADR, for instance. So we have all this information as well. And the next step is to link all of this to the PGX variant, as mentioned. So I hope that this gives you an idea of how we will be using cost effectiveness information in policy making, and very importantly, to highlight the value of sharing data across different disciplines. So from the scientists to the health economists like myself. So this is really, really important. And I will end my sharing here. Happy to contribute during the Q&A session. Thank you.
Thank you very much indeed, Dr. Dr. Hwee will have to move on with the session and sadly won't be able to join us for the Q&A, but she'll take questions by email. I'm delighted to introduce our next speaker, Christian Marshall, who's a medical geneticist and is going to move the discussion forward by telling us how we can quantify benefits beyond research. Thanks.
Thank you very much. There we go. Thank you very much to the organizers for inviting me to speak today, and thank you very much, Carolina, for a very powerful opening talk. I'm a laboratory director that analyzes and reports on hundreds of genomes a year, and it's a good reminder that there's a patient at the end of all of those, and so it's very humbling. And so I'm going to talk today about our experience in Canada, about genomic sharing of data that's generated in the clinical lab. A lot of this work was done by Magda Price, who I would like to call out here, who is leading a lot of this project. So just to kind of give you a sort of a level set, we work in Ontario. I'm in Toronto at Sick Kids, and there's CHEO, the Children's Hospital of Eastern Ontario. Healthcare is under provincial jurisdiction. In Canada, in Ontario, there's about 16 million individuals. It's government-insured genomic testing for those that have a suspected rare genetic disease. We have been doing this now as a funded test. We call it genome-wide sequencing because we do a little bit of exome and a little bit of genome, more shifting to genomes now. Since April 1st of 2021, you can see the number of individuals that we've now sequenced, over 14,000. We've reported out almost 4,600 genomic tests. About 28% of those are diagnostic, and you can see the numbers of exomes and the numbers of genomes there. As I said, we started mainly with exomes, and now we've moved more and more towards genomes. And what I wanted to talk about today was sort of more this all-for-one clinical genomics network. We're calling it the network, and how we're thinking about sharing data, and more importantly, how we're thinking about actually measuring its utility. And so who is participating in the network? Well, right now we talked about CHIO and SickKids. So what we've done is set up essentially a mini hub and spoke model. We do all the sequencing at SickKids, but we send data to CHIO, and they report out on it. We're using Illumina's Imagine platform as a platform to share data. It just happens to be our tertiary analysis platform that we're using. We both have separate instances, but we're really thinking about how to link these. And a lot of this came out of this all-for-one clinical genomics sort of network and project that was funded by Genome Canada to think about how we can share this. And as I said, it's very powerful over time when you're doing this on a relatively small country like Canada and even Ontario. But over time, it's amazing how many samples that you can actually get together, and it certainly makes our job easier when we can share data like this. So how has this been set up? The network sharing is enabled and governed. Members are bound by clinical data sharing agreements. So what we've done is we have a DSA with CHIO right now. It's obviously trusted membership in the sense that these are both health centers and custodians of the data. We do identify it as individual level data sets. Very secure in the sense that we've done privacy and security assessments for the platform that we're using. The consent is an interesting one. This is not a research study. This is clinical data. And there's essentially about a 2-page consent that we ask the patients. So when they're getting the test, if they agree to sharing, and I think it's about 90% have agreed to share data in some form. And then obviously it's very restricted access, right? The feeling is that if patients are contributing to this, then they should. Then the lab should have the benefit of being able to see the data. So what types of data are being shared? There's a couple different levels. I think the first level is really what you would imagine looking at through ClinVar, just a lot of the sort of the variant classifications and descriptions, et cetera. I'm not going to read everything, but you can see it there. And this is the level 1 data that we're sharing sort of no matter what, right? This is level 1, relatively minimal risk. If you look at sort of level 2, this is additional findings. I think in more sort of, more detailed structured phenotypic information, re-identifiable codes, relationships between codes, date of birth, et cetera, and even the diagnostic status. And then there's sort of this level 1.5 that we call in the middle, which is a little bit more of the PHI that individuals will agree to share. So I think a lot of the data that we have, it may not be huge numbers, but it's quite deep in what we have. And why are we sharing it? As I said, in looking at these genomes, obviously there's a lot of benefit anecdotally to sharing in terms of being able to filter the data, get it down to a smaller number, prioritize the variants that we're looking at, and then obviously for interpreting those last few to figure out what's actually potentially diagnostic. So thinking about a genome, there may be about 20,000 sort of coding variants that we want to look at, and trying to get that down into a low number. So really trying to support that high quality genomic testing that's accurate, and it's also equitable for the diagnosis of rare disease. So where are we sharing this? As I said, we're using this Imagine platform. It just happens to be what we're doing. It does enable this sort of network sharing that we have when we can turn this on. We share aggregate data, so we have a large, that 14,000 individuals, we can make an internal allele frequency database, which is very useful for filtering, which I'll show you in a second. We can look at the previous cases and the variants that are in the previous case, so every time I open up a case, I can see all the variants. I can see if that variant has been seen before, and I can open up my network and see other information. And then finally, that sort of gene variant curation. This is actually something that I didn't really think of in the beginning, but you can actually get a lot of information just by looking at the different genes that have been curated over time. And so why does it matter? So thinking about sharing the aggregate data, it certainly reduces the number of variants that we need to review, right? So this makes my job a lot easier. This is a relatively simple graph that is already looking at sort of our preset models of disease. Maybe if you just focus in on the purple one, that's the sort of our known pathogenic variants. And this has already been filtered with NOMAD, but because we can use internal allele data that in the population that we're studying, which happens to be relatively multicultural, you can see that over time, if you use no filter versus a more stringent filter, you can actually really decrease the number of variants that each analyst has to look at. So this really does reduce analyst time. The other thing is that over time we are studying rare disease, but about 36% of the OMIM morbid MAP disorders are genes that we've actually seen and reported on in our data set. Now, not a lot of variants. We are just looking at rare disease. If you see that graph on the left, these are the number of variants that overlap between the two instances, right? There's only about 45. And that's because we're studying rare disease. But if you look at the number of genes that overlap, it's a lot larger, right? So you've got over 500 genes that overlap. This makes it really easy because we have a shared database. We do write-ups on each one of these genes, and then the analyst can go in and just grab that and put it into the report. So this work is already done. So we're building up this knowledge network. The other benefit is really thinking about all the diagnoses that we've made. So because we can do that, we've made a reduction in our reporting time. I don't have the graph here, but you can see over time, the amount of time an analyst spends on a case is actually a lot less. But we were looking to quantify that even more. This is just a graph of the more sort of the more popular diagnosis that we've made. It allows us to kind of evaluate the phenotypic expansion. And identify families that are eligible for clinical trials, et cetera, right? We can go back into our database really quickly and find this information, and you can see some of the more popular databases there. So what's next? As I said, we are sharing within Ontario right now, but in this data set. But as I said, with the help of the All-for-One project that we had, where we really scoped out how to do this nationally. As I said, these are all the provinces in Canada, and each individual province is responsible for reporting out their own. But if we can link these together, I think we have a really powerful thing where we can network. And so you can see that the group in BC has now come on board. And the other groups in Atlantic and Alberta we have agreements in principle to be able to network. So I think turning this on is just going to lead to a lot more data sharing and hopefully a lot more high quality diagnostics. So I'll just end with this. I think what I am hoping to spark discussion about is that we know anecdotally that data sharing is something that's really good. We heard a very powerful story that you can't really put a price on. But this is something that we really feel strongly about, trying to get funding from the government as part of tests, that data sharing is part of it. Because it does take work. It takes work to actually organize and make sure the data is there. We think it can reduce analyst time, therefore we can do more cases. You can have diagnostic accuracy, you can increase, you can avoid reporting out VUSs, which have a whole bunch of downstream effects on the healthcare system. And we're also hoping that by sharing data across the country, that an individual in British Columbia and an individual in Ontario or Atlantic Canada is essentially getting the same report no matter where the test is ordered. And you can do that by sharing the data this way. So really hoping to require building this data sharing and into the cost of the genome testing. And I think this is where we wanted to get some ideas from the GA4GH, how we can actually do that effectively, because I don't know if it's been done really, really well yet. And with that, I'll stop. And as I said, we'll take questions at during the discussion.
Thank you. That's great. Thank you. Thanks very much indeed. And our last speaker before the discussion is going to tell us about the system-wide benefits. Who better than a health economist? James Buchanan is a senior lecturer in health economics at Queen Mary University of London. Thanks.
Okay, good morning, everybody. Thank you for the kind introduction. Thank you also to GA4GH for the invitation to talk today. I'm going to talk about the value of data sharing to advance genomics from the perspective of a health economist. And my focus today is on the value of data sharing between researchers, between studies, national initiatives, to try to facilitate new insights in genomic medicine. I see a couple of familiar faces in the audience, so apologies in advance for anybody who heard me speak on a similar topic in Copenhagen a few weeks ago. So let me set the scene. From a health economics perspective, there are several data sharing activities between researchers, institutions, studies that potentially have value for genomic medicine. In this context, where we're often studying small populations, so in a single study, we rarely have all the data that we need on the natural history of disease, the costs that patients accrue in primary care and in secondary care, the impacts of the disorder on quality of life, on mortality, and then the broader impacts on families and carers that Carolina so eloquently described earlier. Any data sharing activities that could plug these gaps in the economic evidence base have value, and it's important to try to quantify this value because data sharing takes time, it takes effort, and importantly, it takes funding. And evidence of value is enormously helpful to secure this funding. So, how do we value these data sharing activities? Here we go. From a health economics perspective, there are several data sharing activities between researchers. Some of you may already be familiar with how we as health economists determine value in the context of healthcare, which is to conduct what we call an economic evaluation. So when we conduct an economic evaluation, we're comparing the costs and the health outcomes of a new healthcare intervention with those of a comparator, and often this is standard practice. So we're interested in the costs, and we're interested in the health outcomes of a new healthcare intervention. New interventions often improve outcomes, but as you might have guessed, they often cost more money at the same time. So in an economic evaluation, we're trying to answer the question, is the improvement in health outcomes worth it? So is the intervention of value? Now, evidence from economic evaluations helps healthcare providers around the world to allocate scarce healthcare resources in a way that, if we do our job correctly, improves population health. But as you will have probably noted from the previous slide, this approach to measuring value is quite narrow. And it's a problem because data sharing when undertaking genomic medicine research is the value of data sharing in that context is much broader from a health economics perspective. So, for example, in a rare disease context, sharing data internationally on costs, on outcomes, on disease progression, this means we can conduct more robust economic evaluations, perhaps makes it more likely that we come to the correct decision on the value of a new intervention. But quantifying the value of this data sharing is tricky. How much more research would have been required in one country without data sharing across multiple countries? What would the impact have been on population health had healthcare providers had to delay implementation until more definitive health economic evidence was available? And these questions are hard to answer using a very narrowly specified economic evaluation approach. Another example is that sharing data internationally on costs and on outcomes and on disease progression can enable new discoveries and new insights. Ultimately, these may be developed into new healthcare interventions. Again, that might impact on population health. We hope it would impact on population health. These insights might improve patient care in the future through reanalysis of genetic data as well. And again, these potential benefits of data sharing are hard to value within a narrowly specified economic evaluation. We can't know in advance what new interventions genetic discoveries might result in, or how these developments might benefit patients or the broader economy. So, as you might have anticipated, given these challenges, there's not an extensive evidence base on the health economic value of data sharing that I could summarise for you today. But there are a few reasons why I'm quite hopeful that this will change in the near future. First, that there is emerging evidence that I think provides a signal, maybe an indirect signal of the value of data sharing in genomic medicine. Second, there's research that we could be doing now to build the evidence base on value. And then third, I think there are some practical steps that we could take going forward to facilitate data sharing that I think would almost certainly create value from a health economics perspective, and I'll expand on these over the next few slides. So first, the emerging evidence. As we all know, I don't need to tell this audience that the evidence base on genetic variants that are associated with disease is evolving all the time. And this is evidence that's globally relevant. So a new variant discovered in one country and then shared in the scientific literature is immediately relevant to a genomic medicine service in a second country. And that means that there is value in reanalyzing genomic data to take advantage of these new discoveries, and evidence is emerging that this can be a cost-effective thing to do. So, for example, Zornitzer and colleagues reported in 2018 that compared to standard testing practice, if you reanalyze exome sequencing data after 18 months in infants in Australia with rare diseases, this saves money and it improves diagnostic yield. Other work done by Ewens and colleagues came to a similar conclusion. 2 studies in 2018 and 2022, again in Australian patients, this time with suspected Mendelian disorders, found that reanalysis saves money and improves outcomes. So this is indirect evidence of the value of data sharing from a health economics perspective. There are also recent scientific discoveries that would not have been possible without international data sharing efforts, and these could also provide important evidence on the economic value of data sharing in genomic medicine. So one example is the discovery last year of Renu syndrome. This is a breakthrough that was originally made at the University of Oxford using data from the Genomics England 100,000 Genomes project, but confirmation required data sharing across the US, Australia and Europe to identify additional cases. And previously, those with undiagnosed Renu syndrome experienced long diagnostic odysseys over many years, costing, I'm sure in some cases, hundreds of thousands of pounds. But international data sharing efforts have, for some of these children, now eliminated this diagnostic odyssey, and research that quantifies the cost savings and the outcomes associated with this data sharing effort would contribute to building the evidence base on value in this context. And then finally, a key focus in the research that I'm doing at the moment is genomic newborn screening. And I think this is a great example of a field of study in genomic medicine where data sharing could add huge value for health economists. And there are several reasons for this. One is that genomic newborn screening studies typically include hundreds of rare conditions. If we want to model out cost effectiveness, we need data for all of these conditions on natural history, on genetic penetrance, on expressivity, etc. This is data that can't be generated in a single study. We need a global evidence base to move this work forwards. Second is that genomic newborn screening is going to not just yield health outcomes, but will also yield non-health outcomes. And these have value that we should be quantifying, again, as Carolina outlined beautifully earlier. There are impacts on parent anxiety, for example, or on reproductive decision-making. There are actually many instruments that we can use to measure these outcomes, but every genomic newborn screening study around the world is using different instruments, and that limits data sharing. Through the Economic Subcommittee of the International Consortium on Newborn Sequencing, we're trying to coordinate across these studies to make sure that, as much as possible, similar instruments are being used to enable data sharing going forwards. And then third, evaluating the cost effectiveness of genomic newborn screening requires really good data on how this new approach might impact on the acceptability and on the uptake of screening more generally. And again, there's value in combining insights from multiple studies to generate this data and draw global conclusions. And then we may also be able to measure the value of these data sharing activities in real time going forwards. So I've had several conversations with people in national health systems who would like to use the health economic evidence that we're generating in England to support investment in genomic newborn screening in their own country. And that could provide direct evidence on the value of data sharing if it facilitates the implementation of genomic newborn screening when this would not have otherwise taken place. So to sum up, data sharing to advance genomic medicine clearly has value from a health economics perspective. We can conceptualize the mechanisms through which this value could be realized, but there isn't a great deal of direct empirical evidence on this at the moment, because essentially it's quite difficult to perform those calculations. But we can look for indirect evidence on the value of data sharing in genomics, and I've given you the example of reanalysis, and it's definitely worth re-examining recent case studies through a health economic lens, and taking some more practical steps going forward to facilitate data sharing to try to generate more direct evidence on value going forwards. Okay, I'll stop there. Thank you very much.
I can invite the other speakers to join us on the stage, and we still have Dr. Hwee online as well, so we'll be delighted to take questions from the audience through Slido. While you're taking your seats, can I ask you to think about how we make this case to various audiences, and I think the most important is government. There was an interesting contradiction, I think, Dr. Maxwell, so my apologies, you said that you had found that people didn't listen to qualitative data and you needed to quantify, whereas I think Carolina's experience is that she tells such a compelling story that it changes people's minds before her eyes. Are there two different audiences there? Are there some people, do you think, were you talking too much to academics who need everything to be quantified for them?
I think that's a good question, and I was asking myself that after my talk. So I think the frustration is, we need human stories to interpret data because data are not separate from humans. So I think oftentimes we have this idea that the models are going to tell the story themselves, but really humans are telling the story to the models. So I think going back to Hans Rosling basically says, look, we can't use the same tools to solve all of our really heterogeneous problems. And I think telling personal stories, I was almost sobbing because I have a child and I have a friend whose child's almost died from leukemia, and it was, just too close to home. If I could give you all my data, to make your child better, there's no question in my mind. But I think those stories don't work for everyone. And I really don't have an answer as to why. I can't say, but I can say that, oftentimes we see change because of the money, is going to drive economic change in a country. It's going to drive research and development. So I think we need to continue to tell these stories, but we also have to tell other stories, quantitative stories. And I really like the last speaker's point about setting up systems where we can tell stories in real time. Because part of our problem is that we're not speaking a language that's impactful for policymakers. And you can see that we all here have shared goals. Our goals are quite similar to the goals of patients. But those goals are not reflected in the legal structures. So we need to figure out why that is and line up the legal structures with these goals, building health and building better care for different types of patients.
Did you want to comment on that, Carolina?
No, I think I can only agree that, as you say, different message for different groups, depending on what their main issue is and how they can help.
So we have to follow the will of the audience, and there are many questions for Christian, as you'll see appearing on the board. So who and at what point is consent obtained for clinical data sharing, and are you planning to join variant level matcher?
Yeah, I'm looking at the first one. Yeah, and I'm happy to answer any of these questions after as well. So, so consent is obtained when the physician orders the test in this case. As I said, and it's not a research consent by any means. It's a typical clinical consent that we're going to do this test, and your data may be shared if you are okay with that to help other tests. And as I said, I think the uptake on that is roughly 90%, but it actually completely depends on which physician is actually delivering that information. So some are much better at others, and I'd say that some are at 100% when it comes to that. And I will note that we are sharing, as I said, at minimal level, I showed that data, right? Like variant interpretations and everything, we will be sharing no matter what. It's just that deep phenotypic information that we need to help interpret more tests is what we're striving for. And I said that's at about 90%. So I think that's sort of the challenge. But patients generally altruistic about it, and at least this is. I think it's about 2 pages. I'd still think it should be probably even shorter to be able to do this, but
Well, a parent of a patient agrees as well. Yeah, I think strong support from this audience.
Yeah.
There's an important question at the bottom there, which I think I'd invite the whole panel to consider and volunteer to tackle. How do we translate health economic assessments from high-income countries to low and middle-income countries? The question alludes to the need to provide information to key stakeholders in low and middle income countries who need to see the benefits for them of sharing data that obviously can benefit the whole world. Now, that's something we didn't really tackle in this session, but is obviously important for a global organisation. Can I invite anyone to have a stab at that from a health economics perspective? Perhaps?
Yeah, I can see you looking at me first. I think this is evidence that we haven't done a good job of generating so far. Peter actually touched on this at the start, in that this is the sort of, this transition has kind of happened without the need to generate this evidence in a lot of high-income countries. Thus, the evidence base doesn't exist. So I do think that there's a need to build up this evidence base. We're doing increasingly good work on the HTA side, but that isn't the sort of evidence that's going to push this transition. It's a gap in the evidence base. There are examples we can cite, but a lot of it is specific to high-income countries, and there's a need to do work in these settings with focusing on disorders and on mutations that are relevant to these settings, and on generating evidence on costs and on health outcomes and non-health outcomes that are relevant to these settings as well. It's a gap in the evidence base that we need to fill urgently, I think.
Okay, so another controversial topic, popular with the audience. Sequencing platform-specific solutions seem to go against reducing pricing, creating lock-in. Should we use these even when they're cost-effective, if they're locking us in? So that's more of perhaps a moral question, but also a practical one about how we align incentives in industry.
Yeah, so I mean, I was just thinking about this when James was talking, that for the low and middle income countries, like, even though that we are using a commercial solution, and many of you know that Imagine is an Illumina solution and Illumina sequencing, and you do get locked into these things, I do think it's very, very important for us to try to remain agnostic. And even though we do have this solution, I can tell you that I have a large clinical informatics team doing all this, and it's, not everybody can do that. There is a limited number of resources. It's actually not that easy to get the sharing done. And I think what we need to do is at least make sure that the companies and their standards, so that they're adhering to, or at least putting pressure on them, so that the data is very easy to share. And just as an example, like, it's not really easy to get the data from this system into other systems, and it's not really easy as a push button to get it into something like ClinVar, which I think would be very, very useful. And I'm hoping that that would help the low and middle income countries as well at some point. So if we can get this into a point where it's very easy to use and somewhat agnostic, then based on whatever resources there are, they can go ahead.
Yeah, if the cost falls, that clearly will make it easier. I did wonder, James, when you were talking, if, although the absolute benefit might be difficult to quantify without better access to data for research, can the relative benefit of data sharing versus data generation be estimated?
Yeah, I think we can definitely do that sort of work. Yeah, absolutely. And also just picking up on what Christian was talking about, the cost is important, but it's not the most important thing. The cost of sequencing, the actual physical act of sequencing is actually quite a small portion of the whole process. And what happens before you get to the lab and what happens when you have the results in the lab and you take them forwards is also important, increasingly so in terms of the costs. So, it's a valid question to ask, and it's important to minimize those costs, but we also need to think about the cost beyond that step in the process as well.
Carolina, can I ask you about your expertise in dealing with policymakers in the public sector? It's always, in clinical stories, you always prepare yourself for the bits you know are going to be bad, and then something catches you. For me, it was the name of the boat. But it indicates something, I think, that is consistent, that what people want, patients particularly, is not the best treatment or the best doctor. They want compassion and humanity. And I think that does also apply to policymakers. Can you give us any closing advice on how we present the benefits of data sharing to policymakers to compel them to fund it?
What I would say is I also, apart from this, I'm the project manager of the largest open data project in Sweden for public sector. So I live with this every day, even though it's not healthcare data. And I would say to always present the alternative cost and the alternative effects, because it's very easy to look at the effect closest to the cost and it's too much, we can't do it, it's too complicated. But if you start to look into it, as I said, that say we had during our time, we had a lot of support from the Child Cancer Foundation, which made us go back to work probably earlier than we would have otherwise. They made our son finish school and made our daughter also able to stay in school. In that way, society saves a lot of money in the end. And I think you should always be prepared to also talk about that. Say, if we can do this, a doctor may be more efficient in his work and can help more patients. Put on the added effects as well, because that always sticks.
Well, there are a few very specific questions that I think are perhaps better answered directly by email. Lots of people want you to share your data in various ways. I think this session has definitely made the case for doing that. If anyone in the audience came into the room in doubt that their work really matters, I think that this session has certainly answered that. We'll bring it to a close there, and I'd ask you to thank our 5 speakers once again. Thank you.
One quick announcement. By the way, that was a great panel, thank you. If you lost your dietary restriction tag or never got one, right outside near the coffee station is Anna Hendrickson, who can get you another one. You need it before lunch and stick it on your table. Thank you.